So, good evening, esteemed colleagues and guests. It is my distinct pleasure to welcome you to this insightful webinar on drug-induced adrenal insufficiency, organized by Clinical Pharmacology Scientific Subcommittee in collaboration of APICON 2025 with the collaboration of Association of Clinical Pharmacologists and Inovocare e-Academy. So we know the widespread use of glucocorticoids as powerful anti-inflammatory and immunosuppressive agents is a testament to their effectiveness in managing various medical conditions. However, this power comes the responsibility. We have that responsibility to address other accompanying risks. Particularly, today we are going to discuss about glucocorticoid-induced adrenal insufficiency. We know almost there were a very good study which had shown 1% of their population in Denmark, they were taking some about chronic glucocorticoid therapy, which presents significant challenges even in this part of world also, that necessitates ongoing education and vigilant management by healthcare professionals across disciplines. So our webinar today will delve into the intricacies of this condition, exploring the mechanism, diagnosis, and management strategies essentially for preventing and treating adrenal insufficiency. We will discuss the best practices in tapering protocols, patient education, and emerging therapeutic alternatives that could mitigate this risk. As we gather here under the theme of APICON 2025, Empathy, Education, Ethics, I invite you to actively participate, share your insights, and broaden your understanding of this critical topic. Together, we can enhance our clinical practices and improve patient outcomes through informed and compassionate care. So before we begin our discussion today, it is our honor to welcome a distinguished leader in our field, the Scientific Chairperson of APICON 2025, Professor Jyotirmoy Pal, President-elect, Association of Physicians of India. Professor Pal's extensive expertise in internal medicine has been instrumental in advancing our understanding. We are privileged to have him here to share his insights and set the stage for today's discussion. Please join me in welcoming Professor Jyotirmoy Pal sir to this virtual podium for his introductory remarks. Over to Professor Jyotirmoy Pal sir.
Thank you, Dr. Shambho, Professor Shantanu Tripathi, and all others. It is really, I am extremely happy that Association of Clinical Pharmacology, along with APICON Scientific Committee 2025, has organized such a beautiful webinar. Basically, there are so many drugs already are in the market, so many drugs in the pipeline, but every physician should understand the correct and appropriate use of a drug. By a candle, you can enlighten the house. At the same time, you can set fire in the house. So it is not the mistake of the candle. It's not the mistake of the drug. But proper use is very important. Otherwise, that can lead to more catastrophe. So understanding or such type of propagation of knowledge of particularly steroids as such a drug is widely used. And there is a lot of misconception about the steroid. Steroid is virtually the life-saving drug. But many of the patients I heard when we prescribe steroid for some of the indication, maybe some transverse myelitis, maybe STD or other, the patient become afraid. Even in the inhaler corticosteroid, when given for asthma, people refuse to take it. But this awareness is very much important for the physicians, for the practitioners, and also this message to go to the common people that proper use of steroid can save life. It cannot do the harm. So we all should understand the when and how we have to use a particular drug. and what can be the side effect if you do not properly use the drugs. Even if there is side effect, how we can prevent it, how we can early detect, how we can treat it, how we can reverse. Thank you. I wish such type of multiple webinar will enlighten the physicians and practitioners large, and all will be benefited. I wish good wishes for such a program. Thank you, Dr. Shambho. Thank you. Please proceed.
Thank you, Professor Pal, for your encouraging introductory remarks. And at this onset, I want to welcome you all the delegates, because Professor Jyotirmoy Pal sir and his entire team of APICON 2025 give one dedicated session on clinical pharmacology. The physicians today who are present as delegates, the clinical pharmacologists who are present today, I am requesting from the clinical pharmacology subcommittee to please register in our APICON 2025, and you please present your original research there, because now the theme, the leaders also playing in front, like Professor Jyotirmoy Pal sir had already committed, he will present original research article in that conference. Like many other esteemed physicians is going to present their original research articles in this August conference. I am requesting you also please come forward and present your original research article, especially in this field of clinical pharmacology. So all the physicians, all the clinical pharmacologists present today, I am requesting to present your original research article. So as we are talking now about drug-induced adrenal insufficiency, and we are really privileged to have with us Dr. Om Lakhani. And Dr. Om Lakhani, I think, needs no introduction in the field of medicine, in the field of endocrinology, and especially he is one of the pioneer in the field of AI in healthcare, who is engaged in increasing the literacy amongst physicians on artificial intelligence. So we are really privileged to have with us Dr. Om Lakhani, and may I request Dr. Lakhani to kindly proceed for his presentation on this topic on drug-induced adrenal insufficiency. So over to Dr. Om Lakhani.
Thank you, Dr. Shambhu. Thank you so much for the kind words, and thank you for the kind introduction and invitation for this. And thank you to API as well for having me for this meeting. It's always a privilege to speak with learned peers, to discuss, to debate. I think that's the privilege, and I thank you all for having me. So I'll start by sharing my presentation. Yeah, is my screen visible?
Yeah, screen is visible, but voice is sometimes breaking.
Okay, my voice is breaking. Just give me 1 second. Sorry. Hello, is it better now?
Yeah, a little better.
Okay, great. Okay, so yeah. So once again, good evening, everyone, and thank you for having me for this very interesting webinar. And I've been asked to talk on a topic, trust me, is one of my favorite topics. It's a topic which I am very passionate about. It's a topic where, I have done some amount of research as well, and, at least, given a lot of talks on, and that is drug-induced adrenal insufficiency. Now, when I talk about drug-induced adrenal insufficiency or adrenal insufficiency itself, a lot of doctors ask me that, oh, how common is this adrenal insufficiency? Let me tell you. Today, in my OPD, I saw about 30 patients. out of the 30 patients, and I, since I had to give a talk today, I just said that I just want to count the number of patients who come with drug-induced adrenal insufficiency, and so that I can give a kind of a talk on that. And I had 5 patients with drug-induced adrenal insufficiency. You'll be surprised. Out of 30, I had 5 patients labeled or either diagnosed for the first time or labeled already having drug-induced adrenal insufficiency. One patient was given dexamethasone by a local doctor for a long time. Another patient had tyrosine kinase-induced adrenal insufficiency. Another patient was on immunotherapy. Another patient was on inhaled corticosteroids and on and off oral corticosteroids and presented with classical adrenal insufficiency. So the point I'm trying to make is that drug-induced adrenal insufficiency is very common. And for an endocrinologist like me, right, of course, I have keen interest in this. So that's why probably, patients, kind of, there is a little bit of bias as well there. But at the same time, in a OPD of 30, if I see 5 patients with drug-induced adrenal insufficiency, that's a good number to really start with. So this is the outline of my today's talk. I'm going to keep it simple. I'm going to talk about 6 important concepts regarding this. We'll first talk about what is hypothalamo-pituitary adrenal axis. We'll then talk about which drugs lead to adrenal insufficiency and how do they cause adrenal insufficiency. Then we'll discuss the core area, that is glucocorticoids, and how glucocorticoids produce adrenal insufficiency, and then very importantly, how to taper glucocorticoids. Then we'll go on and talk about non-systemic glucocorticoids and how do they lead to adrenal insufficiency. We'll talk about some facts and figures about other drugs that can lead to AI. And then finally, how to recognize and treat adrenal insufficiency. So this is the outline of my today's presentation. So let's start with this very basic concept. What is exactly pituitary adrenal axis? So you can see this figure over here. And this is something which I think most of the elite audience does not require any introduction, but just to reiterate, you have the hypothalamus on the top, right? And this hypothalamus, the hypothalamus produces CRH. The CRH acts on the pituitary gland and produces ACTH. And this ACTH acts on the adrenal gland, producing cortisol. Now that's not all. Remember, there's a negative feedback. So the cortisol that is produced gives a negative feedback to the ACTH and also to the CRH. And this ACTH also has a short negative feedback loop to the CRH. So this is the outline of a typical HPA axis. Now, what are the external factors that can impact HPA axis? So if you have some environmental stressors, for example, patient has physiological stress, the environmental stressors can increase the CRH release from hypothalamus. And if you take glucocorticoids from outside, the glucocorticoids from outside directly inhibit the ACTH and CRH, leading to both secondary and tertiary adrenal insufficiency. So when you give steroids from outside, they produce a form of secondary and tertiary adrenal insufficiency. So this is basically the concept of HPA axis. Now, what is adrenal insufficiency? Very simply, adrenal insufficiency is when you have inadequate glucocorticoid and or mineralocorticoid produced by the adrenal gland. And then there are 3 basic types of adrenal insufficiency. So you have primary adrenal insufficiency, where the disease is because of the adrenal gland. So for example, let's say you have tuberculosis of the adrenal gland, or you have undergone an adrenal surgery, or you have congenital adrenal hyperplasia. All these conditions, you have adrenal gland which is not producing enough cortisol. Then you have secondary adrenal insufficiency that typically occurs when there is reduced ACTH production, and typically occurs, let's say, in a pituitary disorder. For example, if you've got a pituitary surgery, or you have a hypopituitarism, or you have Sheehan syndrome, all these conditions lead to secondary adrenal insufficiency. And tertiary adrenal insufficiency is when you have a disease of the hypothalamus. So for example, let's say you have some tumor in the hypothalamus or the surrounding region, or you are taking drugs from outside. For example, you are taking glucocorticoids from outside, and that leads to tertiary. So glucocorticoids given from outside are the primary and the important cause of tertiary adrenal insufficiency. Okay, let's move ahead and come to the core topic. And that's the very important topic that we're going to discuss today. That is, which drugs lead to adrenal insufficiency and how. Now, a lot of you would have seen my other videos and other talks on glucocorticoids, on glucocorticoid-induced adrenal insufficiency, other things as well. But so there'll be some repetitions in a lot of these talks of mine. But at the same time, I'm going to give you some very crucial and important new information as well. So hang on to this, because there is something very interesting and something very important that we are going to discuss, especially the tapering of steroids. And that's something which I really feel is important. And also we'll discuss some important drugs which not many people know also lead to adrenal insufficiency. So just hold on to this talk, because we are going to discuss something very useful in clinical practice. So which drugs lead to adrenal insufficiency? Now, anybody who wants to read a very good article on this topic, I think this is the reference here. You can see the reference here. This was published in the Journal of Endocrinology and Metabolism, JCEM, right? So this is the list of, and you can see here, the list of all the drugs that can lead to adrenal insufficiency. Now, something very interesting is that the new kid on the block, the new drugs which are, nowadays reported frequently to produce adrenal insufficiency are the monoclonal antibodies. We'll discuss a little bit about this topic as well. So you have all of these ipilimumab, nivolumab. These are all used in immunotherapy in cancer. And these are very, very important causes of adrenal insufficiency. In fact, like I said, of the 5 patients that I saw today, one of these patients was on monoclonal antibodies. Looking ahead, you have glucocorticoids, and all forms of glucocorticoids can lead to adrenal insufficiency. Of course, the potency of the glucocorticoid and the duration of the glucocorticoid are very important. We'll discuss these points as well. Interestingly, beta-2 agonists also have been reported to produce adrenal insufficiency. Some other hormonal therapies, for example, somatotropin, levothyroxine, and I'll discuss a case of ours, megesterone, right? These are all hormones can lead to adrenal insufficiency. And a very important drug, and I'll tell you a story of this one patient of ours, is abiraterone. This is used as a drug in prostate cancer, and this is also known to produce adrenal insufficiency. Then you have antiviral drugs like ritonavir. Ritonavir is used in HIV, and that's again leads to adrenal insufficiency. Fluconazole, itraconazole, right? Drugs used for Cushing syndrome. Naturally, drugs used in Cushing syndrome will lead to adrenal insufficiency. So you have octreotide, pasireotide, ketoconazole, metotane, metarepone. All of these lead to adrenal insufficiency. Protein kinase or tyrosine kinase inhibitor. I told you another patient today. Today we saw one patient with tyrosine kinase inhibitor induced adrenal insufficiency. Antithrombotics. Of course, heparin directly does not lead to adrenal insufficiency, but heparin can lead to, indirectly can lead to adrenal insufficiency. Alendronic acid also, there are case reports of that. Very important drug, rifampicin. We'll discuss this. And another very important drug, tramadol. These are again 2 drugs we'll discuss in detail about how and why they lead to adrenal insufficiency. So these are some very important drugs that you cannot miss that can lead to adrenal insufficiency. And this is very, 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 very important that you know that these drugs can produce these condition and they can lead to adrenal insufficiency. Now, jump to another favorite topic of mine, that is glucocorticoids, and how glucocorticoids produce adrenal insufficiency and how you will diagnose it, how you will treat it, right? So that is what we'll discuss. Now, this is a case, this is of course an old case of mine. I saw exactly similar patient today in my practice. So this was a 40-year-old patient from Haryana. This patient looks Cushingoid, right? So that anybody, maybe a first year MD medicine student or even a first year, a DM resident in endocrinology will make this diagnosis very easily. This is a patient with classical features of Cushing syndrome, right? And there's another patient with Cushing syndrome, right? Now, we saw these patients who looked like Cushing syndrome. But very interestingly, when we did baseline cortisol of this patient, we had low cortisol, right? Now remember, the cortisol values, we'll discuss this as a point, but cortisol value typically less than 3 are considered definitely low. So this patient had a cortisol of 1.2, which was low. So when you have a patient who looks like having Cushing's, but has adrenal insufficiency, what is your diagnosis? The diagnosis is patient is having iatrogenic or exogenous Cushing syndrome with tertiary adrenal insufficiency. This is a complete diagnosis, okay? Exogenous Cushing syndrome with tertiary adrenal insufficiency. And which is the most common cause of Cushing syndrome in India, or in fact worldwide? It is iatrogenic Cushing. Exogenous Cushing's is the most common cause of Cushing syndrome worldwide, right? So rather than endogenous Cushing, exogenous Cushing is much, much more common. Now, basically, how does a Cushing syndrome or how does exogenous steroid produce adrenal insufficiency? Like I already told you this, you take glucocorticoids from outside. Glucocorticoids taken from outside has a negative feedback on ACTH as well as CRH, and this leads to tertiary adrenal insufficiency, right? So the form of adrenal insufficiency that you see in this condition is tertiary, okay? So this is a very important thing you have to understand. It leads to central or tertiary adrenal insufficiency. And here, this one point you have to remember, right? So when you have primary adrenal insufficiency, you have deficiency of both glucocorticoid as well as mineralocorticoid. So you have to replace both the glucocorticoid as well as mineralocorticoid, right? So the glucocorticoid you'll have, of course, you'll give oral glucocorticoids. But mineralocorticoid, you'll have to go fluorocortisone, right? Whereas when you have secondary or tertiary adrenal insufficiency, right, like you have in case of exogenous steroid, in this the deficiency is mainly with glucocorticoids and not mineralocorticoids. And because you have just glucocorticoid deficiency, you just give glucocorticoids and do not give mineralocorticoid. There's no role of mineralocorticoid here. Okay, so this is a very important point, which again physicians and clinical pharmacologists should be well aware of. Now, when should you suspect a patient having tertiary adrenal insufficiency? Now, patient will sometimes be screaming that, look, this is my diagnosis, but not always. Sometimes, a lot of the times, the diagnosis is not very, very clear. And in that case, you will have to kind of, dig through the patient's history and maybe search out the diagnosis, because sometimes the diagnosis may not be very apparent. So when do you suspect an adrenal insufficiency? So we have a patient who takes medications from, I mean, should not use the word, but from quacks for diseases like arthritis, asthma, COPD, PUO, right? Like the patient I saw today, the patient used to have some generalized weakness, and every time he would go to a local quack, he would give them an injection. This injection was most likely dexamethasone, right? And the patient would feel better, right? So that's a very typical thing that you see in smaller villages and other things. Typically, the patient appears Cushingoid, but the baseline cortisol is low, right? This is the classical feature. Sometimes the symptoms may be more subtle, right? Sometimes the patient will complain of a weight gain. Sometimes the patient will complain of some vague symptoms. The patient will have some skin lesions, right? So all these things is very, very important. And history taking is something which is very, very crucial for these types of patients. Subtle cases may be unexplained weight loss, skin changes, unexplained osteoporosis or vertebral fractures, unexplained hypoglycemia or hyperglycemia, right? So what happens is when the patient is on steroids, the patient's blood sugar goes up, but then suddenly the steroids are stopped, it can lead to hypoglycemia, right? So this is something which is very important. And hyponatremia. This is something very important, right? I mean, the number of cases in our hospital alone that have been diagnosed with adrenal insufficiency because they presented with hyponatremia after I joined the hospital has tremendously increased. Now, I again don't want to take credit for it. The point I'm trying to tell you is that a very important cause of hyponatremia is adrenal insufficiency. Please remember this. Again, very important point I'll tell you here, that when you have primary adrenal insufficiency, you tend to have hyponatremia with hyperkalemia. And when you have secondary or tertiary adrenal insufficiency, you just have hyponatremia without hyperkalemia, right? So you have normal potassium. In fact, potassium may be low or normal, right, in secondary or tertiary adrenal insufficiency, right? So this is a very, very important point that you should be all well aware of. Now, let's come to a very important area, that is, so we understood that glucocorticoids can lead to adrenal insufficiency, but now we need to know how and when to taper glucocorticoids and what doses of glucocorticoids need tapering, what doses of glucocorticoids do not need tapering. So it's a very practical point that you have to understand. Now, this slide, I think, is something which I show many, many times, and this is very, very important. Which patients are likely to have hypothalamic pituitary adrenal axis involvement or HP axis involved with glucocorticoids? 3 rules. Any patient who has been on more than 20 milligram of prednisolone for more than 3 weeks. Any patient who is more than 5 milligram of prednisolone given in a non-physiological manner, that is at night time, for more than 2 weeks. Or any patient who has clinical features of iatrogenic Cushing syndrome and clinically looks Cushingoid. This patient is also somebody who has HP axis, likely to have HP axis suppression. So these 3 rules you have to always remember. And if you remember these 3 rules, it is very important that any patient who is on these kind of things require tapering, right? So these patients require tapering, right? So this is something which is a very, very important rule that you need to remember and you need to appreciate and understand, right? So to taper or not to taper, right? So when should you taper? So any patient who is on glucocorticoid less than 3 to 4 weeks of therapy, right? Regardless of the dose, right? So even if the patient has been on high dose, regardless of the dose, you can consider directly stopping without tapering. Any patient who is on long-term glucocorticoids, right, should, if the underlying, so you have to remember one thing, that if the patient's underlying disease is not controlled, right? And this is where I'll talk to you about the concept of therapeutic taper versus endocrine taper. If the disease is not controlled, you do not take. Patients on long-acting steroid should be then switched to shorter-acting steroids, right? When you're tapering, and this is something, again, I'll discuss in a few minutes. And then when you reach the physiological dose, then you need to monitor the patient's HPA axis also while tapering. And one very important rule, which I have not written here, you have to remember, and that is that when you're tapering these doses, okay, when you're tapering these medications, sometimes the tapering period can be very, very long. In fact, the HPA axis may take from 9 weeks to anywhere between 9 weeks to 9 months, even years for it to completely recover, right? So it takes a long time for the HPA axis to recover, and hence patience is very, very important, right? So a general rule of taper is that, like I said, you have to go from a more potent glucocorticoid to less potent glucocorticoid. So let's say your patient is on dexamethasone, then you go to prednisolone, and then you go to hydrocortisone, oral, right? Oral hydrocortisone is available in India. Again, a lot of doctors are not aware, but oral hydrocortisone is available as a brand called Hyzon. Again, no promotion of any brand. I'm just telling you, right? I have no financial relation with this, but the point is that oral hydrocortisone is available in India. So you go from a more potent to a less potent glucocorticoids as you are going in terms of tapering. Okay. Now, here is where a very important concept I like to bring to you. And this is something, we have this discussion with our, colleagues from pulmonology, colleagues from rheumatology. There is therapeutic taper versus endocrine taper. Especially, I have this discussion quite often with our rheumatologist, right? Something very important we need to understand. Now, what is therapeutic taper? What is endocrine taper? Now, therapeutic taper means that you bring, so let's say the patient requires glucocorticoid for any condition that requires immunosuppression or whatever reason. Then what you have to do is you have to bring the patient's steroid down from the higher dose to the lowest possible dose as guided by the disease itself, right? So let's say patient has some form of rheumatological, let's say patient has SLE and his patient is responding to glucocorticoids, then you have to bring the glucocorticoids down to the lowest possible dose which the patient can tolerate and have least amount of side effects, right? So that's the therapeutic taper. Now, if the underlying disease does not require glucocorticoids anymore, and the patient fits the criteria for tapering, then you have to bring the dose down to a physiological dose, right? Now, this is a very important point, right? You have to bring the dose down to physiological dose. What is a physiological dose? A physiological dose is typically 15 to 25 milligram equivalent of hydrocortisone or 4 to 6 milligram equivalent of prednisolone. Okay, simple rule: 5 milligram of prednisolone, right, or less than 5 is a physiological dose. So anything less than 5 milligram, 5 or less than 5 milligram is considered a physiological dose equivalent of a physiological dose of a steroid, right? So let's say a patient is, for example, let me give you, let's say patient is on, let's say, having lupus, and patient requires glucocorticoids, but now the rheumatologist feels that the glucocorticoid is not required, maybe a second line agent or some other steroid sparing agent can be given. Let's say the patient has been on 40 milligram, right? So then you have to bring that patient down to 5 milligram of prednisolone, right? And this is known as therapeutic taper, right? So this is the first phase of tapering, that is therapeutic taper, that is to bring the dose down to a physiological dose, right? So that's something which is very crucial and very important for anybody who deals with glucocorticoids. Now, next part is where the endocrinologist comes into picture, right? So when you have done the therapeutic taper, I think what I'll suggest is any doctor who deals with any form of steroids needs to learn how to do therapeutic taper. Therapeutic taper is not endocrinologist domain. You can't send a patient for therapeutic taper. Therapeutic taper can be done by any doctor, right? So that's something which needs to be done by the treating doctor, whatever reason you have given steroids for, or anybody else is given steroid, you need to do the therapeutic taper. But the endocrine taper has to be done by endocrinologists. This is something, what I strongly believe. Of course, the guideline says that, it can be done by some non-endocrinologists also, but I strongly believe that right now, in today's world, if you want to do an endocrine taper, so you want to stop the steroids. What I'm saying is the patient is brought down. Now the rheumatologist has brought the steroid down from the whatever dose that was to the physiological dose. Then his job is done. From bringing the physiological dose to 0, that is where the endocrinologist comes into picture, and that is where you do the endocrine taper, right? So this is something which is very important. So endocrine taper comes when the patient's dose is close to the physiological dose. This is where the tapering has to be done more slowly, more cautiously, and while assessing the HPA axis. again, you need to see and look for signs of adrenal insufficiency. So the idea is to balance between giving steroids and looking at the HP axis and recovery of HP axis at the same time, looking at the signs and symptoms of adrenal insufficiency. So you have to balance this out, and this balancing, because because endocrinologists are very keen at making a diagnosis of adrenal insufficiency or recognize this very easily. That's why this is something which should be done by endocrinologists themselves. So this is the taper sequence I already discussed to you. So patient starts, let's say a patient is on a supraphysiological dose of glucocorticoids for more than 3 weeks. So let's say a patient has been on, let's say prednisolone of 40 milligram. Then first phase is to do a therapeutic taper, and therapeutic taper is to bring the dose down to 5 milligram equivalent of prednisolone. And then you do the endocrine taper. And this endocrine taper, what endocrinologists typically will do is to shift the patient from a prednisolone to a oral hydrocortisone. We generally give 10 milligram at 8 a.m. in the morning and 5 milligram at 4 or 5 p.m. in the evening, right? So this is a typical dose that we give. And then the endocrinologist gradually reduces the dose of hydrocortisone by 5 milligram every 2 to 4 weeks, looks for clinical cues of both adrenal insufficiency as well as glucocorticoid withdrawal, right? And keeps assessing the HP axis until you have complete recovery of the HP axis. And then you can safely say that the patient is completely off steroid, right? So it is not as easy as you think, right? There is a science and art behind it, right? And this is where the endocrinologist really comes into picture when you're tapering. Right. Now, when you're doing this taper, right, and this is where, when you're tapering the dose, there is a point of time where you have to keep assessing the HP axis, right? So a simplest way of assessing the HP axis is to measure the morning cortisol level, right? And the morning cortisol, remember, has to be checked. So if the patient is on hydrocortisone, so and just today, in fact, I saw a patient where we did this, right? So you have a patient on hydrocortisone 10 milligram at 8 a.m. and 5 milligram at 5 p.m. So when I order the cortisol, the patient has to skip the afternoon dose of the hydrocortisone and do the test before the morning dose of the high zone, right? So that's the rule, right? So you have to do a morning cortisol with at least 24 hours stopping of oral hydrocortisone, right? So that's the typical way. And you do the morning cortisol level, and this is the interpretation of that. So if you're doing a morning cortisol, if the level is more than 10, that means the HP axis has recovered and the glucocorticoids can be stopped. If it is less than 5, then you need to continue the physiological dose of glucocorticoids till a few more weeks and then keep repeating. If it is between 5 to 10, this is where you can take a judgment call, right, depending on the clinical status of the patient, other things, right? Here you can use other tests also. So you can use something like an ACTH stimulation test, or you can consider using DHES. These are some useful tests for measuring in between levels, right? So this is how you typically do. Okay, so what I showed you earlier was the guideline as per the Endocrine Society guideline for tapering, but we have our own sequence for tapering, and this is based on multiple research papers. Again, this is not published, so we are not published this as a paper, right? So again, you need to kind of and Dr. Shambhu would say that why don't we publish this in the API conference as an abstract? Absolutely, would look forward to, right? It's a great idea, right? So what is our sequence? What is our taper sequence? What we typically do is we reach the physiological dose of glucocorticoids, then we switch to oral hydrocortisone, right? And we switch to oral hydrocortisone, we monitor the patient with a DHEAS. Now, you'd ask me why DHEAS, right? So DHEAS, remember, the thing about DHEAS is that DHEAS has a lot of benefits over morning cortisol level. First and foremost, you have to understand that when you're giving the oral steroid, right, oral glucocorticoid or oral hydrocortisone, sometimes the drug itself gets sort of cross reacts with the assay, and that the drug itself gets sort of recognized by the assay. But when you doing a DHEAS is something which is completely independent of the assays, right? So that means the assay cross reactivity of the assay is not there. Secondly, very importantly, DHEAS has a longer half-life compared to cortisol. It generally has a value which stabilizes over a period of 2 weeks. So it's like something like doing a glycated albumin instead of a random sugar, right? So it gives you a more longer period of time, a value for a longer period of time. So the HP axis, what you're assessing is over a period of 2 weeks when you're doing a DHEAS instead of just measuring at point blank, right? So that's something which is very useful. So what we do is, instead of measuring the cortisol, we measure DHEAS in our practice, and we serially look at the DHEAS values, right? Now, so right, all my patients, on steroids, and when they're sent to me for tapering, I monitor it using the DHEAS, right? Now, you serially see the DHEAS value. Now, the DHEAS value has been serially increasing. Now, remember this point, okay? So again, let me show you this by diagram here. So remember, the ACTH, which is produced by the pituitary gland, that acts on the adrenal, right, to produce, remember, it does produce cortisol, but it also produces DHEAs. Okay, so this is something which is essential to understand. Now, what happens is that, if the DHEAs, right, is so what we are trying to do is we are trying to see, remember, when you're giving steroids from outside, it is tertiary adrenal insufficiency. It's basically CRH and ACTH. So we are seeing the recovery of CRH and ACTH. Okay, so to see the recovery of CRH and ACTH, we are using DHEAs as a surrogate marker. So that's something which I'm trying to illustrate. So what happens is that if the DHEAs patient is on steroid and the DHEAs value is increasing, what does it mean? It means that the ACTH is this axis upstairs is recovering, right? So it's a very assuring sign. So when you have a patient on glucocorticoids and DHEAs value is increasing, I often rapidly taper glucocorticoids. That means because it gives me a lot of assurance that the patient's CRH and ACTH are doing well, and I taper that very rapidly over a period of weeks. But if the DHEAs value is either static or reducing, that means that two things: either the underlying disease itself, is a problem, or it means that the ACTH and the CRH axis, the HP axis, has not completely recovered. So in that scenario, I often see what is known as a DHEAs ratio. So remember, the problem with DHEAs is that DHEAs is something which changes according to the age and gender of the patient. So older people tend to have less DHEAs. So you look at what you do is you calculate the DHEAs ratio. DHEAs ratio is calculated by the actual DHEAs value divided by the lower limit for the age and gender, right? Now these values you can get from your labs, and you can also get it. Sometimes it is printed in the report as well, or you can get, there is a paper in JCM, you can search for it, right? That paper also gives you the lower limit for different ages, right? So you calculate the ratio. In fact, we have made an app also. We're not still put it up, so we'll put it up. We have something called endodynamic, where we'll put that up, right? So if the DHEAs ratio is less than 1, that means that the DHEAs is not completely recovered, in which case you do continue the same dose or do a very slow taper. When it is more than 1.2, it is again quite reassuring. So I do a more rapid taper. If it is 1 to 1.2, that is where you do take a slow taper as well in that condition as well, right? So generally, if it is less than 1, here I say, of course, I said slow taper, but I generally continue the same dose, right? I don't even reduce the dose of glucocorticoid, right? So this is something which I typically use in my practice for tapering of the dose of steroid. It's a little complex, but when you start using this, it's actually very simple. This is simpler than the measuring of the cortisol, and it is less erroneous than measuring the cortisol. Now, I hope you enjoyed the sequence on tapering, but now let's go to the other aspects of adrenal insufficiency. That is looking at non-systemic glucocorticoids, and do they lead to adrenal insufficiency? So the simple answer to this is yes. Okay. Now, inhaled glucocorticoids definitely lead to adrenal insufficiency. Topical application, rare, right? Depends on clinical situation. Sometimes the patient has had a very severe loss of skin and very potent topical steroids have been used, that can lead to adrenal insufficiency. Intra-articular glucocorticoids and new guidelines, of course, this slide I made some time back, but the new guidelines categorically says that intra-articular glucocorticoids potentially definitely leads to adrenal insufficiency. Intranasal spray, rarely, it doesn't generally lead to adrenal insufficiency. Ophthalmic application does not lead to adrenal insufficiency. So the ones which are really concerned about are inhaled glucocorticoids and intra-articular glucocorticoids or steroids. These are the ones where adrenal insufficiency is particularly known to happen, and particularly something you have to look out for. Now, inhaled glucocorticoids, you have to be cognizant of this fact that not all of them are directly deposited in the lung. About 10 to 60% gets deposited in the lung, but 40 to 90% gets orally swallowed. So even though inhaled glucocorticoids are better than oral glucocorticoids, some of it is swallowed and then definitely has systemic effects also. So you have to understand that it is not all rosy. Inhaled glucocorticoids are not 100% safe. They definitely lead to HPA axis involvement also. And particularly, remember the potent steroids, right? So fluticasone, right, is particularly potent and particularly nasty when taken for a long time to lead to adrenal insufficiency. So that's something you have to be very well aware. Inhaled fluticasone is something you have to be aware about and can lead to adrenal insufficiency. So again, if you're dealing with a COPD patient, this is something you have to be well aware about, especially perioperative period and other situations, right? So you have to be careful about these things, right? Now, Let us then, so we looked at the glucocorticoids. Now let's look at some other drugs that can lead to adrenal insufficiency, because today's topic is not just looking at steroids, but looking at all the drugs that can lead to adrenal insufficiency. So we'll talk about 6 different drugs. I'll tell you some stories about these patients also. Very importantly, anti-cancer drugs. This is something you have to be, any patient on oncology therapy, right? A lot of these oncology patients have adrenal insufficiency, lot of them, right? So you have to be very careful. Drugs itself can lead to adrenal insufficiency. Also remember, a lot of these patients are on chemotherapy. And when chemotherapy is given, a lot of these patients are given dexamethasone. So it is very important to understand that these patients will have adrenal insufficiency unless proved otherwise, right? This is something which oncologists also need to understand. And any oncosurgeon who operates this patient also needs to understand that this is something which is very important, right? Now, the earlier study which I had shown by Rashi, what Rashi had also shown is that the changing phase of adrenal insufficiency, I can see from here, earlier, a lot of these cases where most of the adrenal insufficiency cases were reported because of steroids. But these days, and this yellow is basically, I'm sorry, that got cut off, right? So yellow is basically representing the, the immunotherapy, right? And the number of reported cases of adrenal insufficiency because of immunotherapy has rapidly increased over a period of time, right? So that's something we have to be very well aware about, right? And that's something we have to be cognizant about, right? Now, the immunotherapy, the important drugs that can lead to adrenal insufficiency, you have this immune checkpoint inhibitor, right, which is called as ipilimumab, right? This can lead to pituitary involvement. So it can lead to secondary and tertiary. So it leads to hypophysitis, right? It leads to pituitary involvement known as hypophysitis, and that can lead to adrenal insufficiency. And the PD-1 inhibitors like nivolumab, these are very popular in India, can directly lead to adrenal involvement, sometimes can lead to thyroid involvement also, and can lead to pancreas involvement and type 1 diabetes also. But they can lead to primary adrenal insufficiency. So they can directly involve the adrenal gland, leading to primary. And we had a couple of patients with these type of things as well, right? In fact, we had a lot of patients with immune checkpoint inhibitors on, leading to adrenal insufficiency. Another very interesting drug and very important drug that can lead to adrenal insufficiency is abiraterone. Now, abiraterone is a very popular anti-cancer drug for prostate cancer, right? And it almost certainly leads to adrenal insufficiency. In fact, the oncologists who give this drug are aware of this fact, and they also simultaneously give glucocorticoids in these patients on abiraterone. Right now, abiraterone, remember, is a CYP17 enzyme inhibitor, and it directly inhibits the cortisol pathway. Because it directly inhibits the cortisol pathway, it leads to adrenal insufficiency. It's very simple mathematics. There's no complication about it. Unfortunately, this is often missed out, right? We had this patient who was, who had some problem and then got admitted in some hospital outside, was very sick. Patient was on abiraterone, which one relative knew about it, but the other relatives did not know about it. Right? So patient got admitted, patient developed hypertension, developed other things, and ultimately the patient ran away from that hospital. The patient was shifted to our hospital. When the patient came to our hospital, right, we started taking the history, and the other relative who actually knew about the patient better came and said that he's on some cancer drug. I said, what cancer drug? So he had prostate cancer. He was taking some drug for cancer. Immediately, my sort of bell started ringing. So I asked him to bring the drug. It was abiraterone, and we started the patient. Patient actually had adrenergic crisis, and we started the patient on glucocorticoids. Patient became better. Patient went, right. So I think that's something which good history taking again is something which is very crucial and sometimes often missed out. Another very important drug that leads to adrenal insufficiency, and that is what again we all need to be aware about, right? This is very popular drug, very frequently used and misused, right? That is tramadol. Okay, tramadol is a very important drug that can lead to adrenal insufficiency. Tramadol, long-term use especially, can lead to HPA axis suppression and can lead to adrenal insufficiency. So it does lead to tertiary form of adrenal insufficiency, and that's something which is very crucial and very important for you to understand. And this has been proven in humans as well as in clinical experimental findings in rats also. So long-term tramadol use, in fact, we had about 5-6 patients on our follow-up who are tramadol-induced adrenal insufficiency, right? They've been taking tramadol for a long time, and they have this typical history, right? Another in the similar class, opioids, right? Now, again, a lot of, I don't know, if it's common in your parts of country also, but we see a lot of patients in Gujarat, we see a lot of patients from Rajasthan, Haryana, and Punjab, and the amount of opioid used in these states is tremendous, right? I'll be really surprised that a lot of patients, almost every third patient is on afim, right? And afim or, opioids or marijuana, right? All these things lead to adrenal insufficiency, especially chronic use, right? Very common, very important, very commonly missed out, right? So opioids, especially chronic opioid use, whether it was for recreational use or sometimes, therapeutic use also, like, for example, tramadol also, you can consider the same group, can lead to adrenal insufficiency. Again, we had one patient with classical, adrenal insufficiency because of opioids, right? Again, leads to tertiary adrenal insufficiency. So that's something you have to be aware about. And this patient was classic. Again, a lot of people missed out the diagnosis. We made the diagnosis, patient became better, right? Now, another fifth fact and very important fact, and this is our paper, which was published, this is a paper published by us, right? A case report, which was published by us. So levothyroxine, right? Now, levothyroxine, in fact, this has been quoted in the earlier article, our paper has been quoted, saying that, levothyroxine, as a reference has been quoted. The point I'm trying to make is that, of course, levothyroxine itself does not lead to adrenergic adrenal insufficiency. It can unmask an adrenergic crisis, right? So a patient who has simultaneously adrenal insufficiency with hypothyroidism, if you treat the hypothyroidism first, the patient's adrenergic crisis, the adrenal insufficiency can get unmasked and can precipitate an adrenergic crisis. That's exactly what happened in the patient which we had reported as a case report. So that's something which you have to be very well aware about. Again, in a patient with a pituitary disorder also, when you have both the hypothyroidism as well as adrenal insufficiency, when you treat the hypothyroidism before adrenal insufficiency, then you can precipitate a crisis. So that's something, again, you have to be well aware about in your practice. Fact number 6, CYP3A4, right? 3A4, induced adrenal insufficiency, or drugs or substances that inhibit CYP3A4, like grapefruit, can increase cortisol level, right, by reducing its metabolism. But the drugs like rifampicin that increase cortisol metabolism, so that's something you have to be aware, right? So when you have CYP3A4 inducers, the patient can have adrenal insufficiency, or the patient is on steroids. So let's say a patient is on glucocorticoids, patient has adrenal insufficiency, and you introduce rifampicin, and you need to increase the dose of the glucocorticoids to prevent adrenergic crisis, right? So that's something you have to be very well aware about. Again, clinical pharmacologists are well aware about these things. So again, as clinicians, we also need to be aware about these things, right? So rifampicin, remember, rifampicin has been reported to produce adrenal insufficiency. It can actually worsen existing adrenal insufficiency in patients with tuberculosis. A lot of patients with tuberculosis have adrenal involvement. This is again frequently been reported in case reports and across the country. And patients on physiological glucocorticoid doses need to increase the dose when glucocorticoid has been prescribed, right? So rifampicin is something you have to be well aware of, right? So these are the points, right? A lot of drugs, of course, I did not cover. Ritonavir, I already told you, right? Important cause, and fluconazole, right? Fluconazole, itraconazole, all of them can lead to adrenal insufficiency. So these are something you have to be, again, well aware about and be cognizant of these facts, right? Now, how to recognize, diagnose, and treat adrenal insufficiency? Again, how do you establish the diagnosis? So this is again our own, sort of flow chart. Very interestingly, this has been now replicated in a lot of guidelines. Very similar. Again, I will not take credit for these things, but sometimes, great minds think alike. That's again what I say. So how do you assess the HP axis, or how do you look for adrenal insufficiency? So what you do is a morning cortisol, DHES, and DHES sample in fasting. So whenever I'm looking at adrenal insufficiency, I do send these samples in morning fasting. If the value is less than 5, definitely the HP axis is compromised. If it's more than 12, it is generally considered to be normal. But if it is between 5 to 12, that is where you are looking at the somewhere in middle, right? And here we look at the DHES ratio. Okay, so DHES ratio, again, I already told you. Now, in that context, the ratio we are seeing in a different way. Here we are seeing with a more margin ratio. So if it's more than 1.8, it is considered to be normal. Less than 1, it is considered to be HP axis compromised. And 1 to 1.8, this is where you go for a ACTH stimulation test. And this is the little app we have made for calculating the DHES ratio. This I use in my own practice, but again, it's not available for you, but we'll make it available. And like Dr. Shambhu said, I'm very interested in AI and computational medicine, etc. So this is something which is part of my little bit of a project. So if the value is between 1 to 1.8, that is where you do a ACTH stimulation test. And if the post-stimulation cortisol is more than 18, HP axis is normal. If it is less than 18, HP axis is considered to be compromised, right? So that's something which is very important, right? So this is the protocol for ACTH stimulation test. Again, endocrinologists listening to this don't need to be taught. This is very simple. They already understand this. Remember, you don't need to have a fasting sample, or don't need to have. You can directly, anytime the patient comes, you can administer 250 microgram of synactin, and you have to take a sample at 0, 30, and 60 minutes. A 0 sample is not necessary, right? So even though this is from one of the guidelines, but a 0 sample is not required. You can directly do a 30 and 60 minutes. If patient is already done, I'm assuming that a fasting baseline cortisol has already been done. Right now, if any of this value is more than 18, it is considered to be normal. If it's less than 18, that means that the HP axis is compromised. So that is the ACTH. This is called high dose ACTH stimulation test. There is another one called low dose, which uses 1 microgram of ACTH. But again, we'll discuss that in a separate forum. I think that something which is important, right? So morning cortisol less than 5 has 100% specificity and sensitivity for making a diagnosis. However, there are certain guidelines say which less than 3, but I think again it's err on the side of caution. I think 5 is a better cutoff to deal with, right? Upper limit that rules out adrenal insufficiency is, again, newer guidelines and newer studies says 12. Older guidelines used to say 18, right? But again, that would depend. Remember, the cortisol value depends on the clinical circumstance also. So you have to look at the physiological stress. And again, if you're not very sure, it's always better to send it to an endocrinologist who will be able to do better, right? So we already looked at ACTH stimulation test in detail. Okay. Now, when you have already established that the patient is having adrenal insufficiency, you want to see whether it is primary or secondary versus tertiary. In that case, again, something which is very useful is to do a ACTH level, right? And if the morning ACTH level is more than 100, if it is definitely primary. If it is less than 20, it is secondary or tertiary. If it is between 20 to 100, that is where the gray zone lies, and that you may not be able to very clearly recognize whether it is primary or secondary or tertiary. Actually, it does not make too much difference in management, except for the fact that primary adrenal insufficiency, you will be giving fludrocortisone, whereas other cases you will not. DHEAS we already discussed about, right? So it's a useful test and it's an emerging test which is very, right? Finally, the last part of my presentation is management of adrenal insufficiency. In the management, primary adrenal insufficiency, when a patient comes in an acute crisis, you give IV hydrocortisone. In chronic cases, you give oral hydrocortisone or oral prednisolone and oral fludrocortisone. Now, DHEA supplementation is an area of debate. Again, completely different debate, completely different topics. We'll not discuss here. But what I already told you this earlier, that primary adrenal insufficiency, you give izone, oral hydrocortisone with oral fludrocortisone, right? So that's something which is useful. And secondary adrenal insufficiency or tertiary adrenal insufficiency, again, in crisis, you give IV hydrocortisone, but in chronic cases, you can give oral hydrocortisone or prednisolone. I do not prefer dexamethasone. So again, it's not a very good idea to give DEXA, even though, of course, this is taken from some guideline, but preferably to give oral hydrocortisone or oral prednisolone, right? So to summarize, some practical take-home message. Remember, first about glucocorticoids. Glucocorticoids given more than 3 weeks in doses more than 20 milligram per day of prednisolone or equivalent can compromise HP axis. In such cases, tapering of steroids are required. Non-systemic glucocorticoids like fluticasone or inhaled glucocorticoids can lead to adrenal insufficiency. And drugs like anti-cancer drugs, rifampicin, tramadol, all of them can lead to adrenal insufficiency. So again, you need to be vigilant. Third take-home message: DHEA is a very useful test for early diagnosis of adrenal insufficiency, and it's also useful for follow-up of patient with tertiary or patients on tapering, right? DHEA is a very useful test. So again, one of my favorite tests. All my lab people know that, if DHEA is sent, it has to be home, right? So that's the idea. So thank you for a patient listening, and I'll hand it over back to the organizers for taking this forward. Thank you.
Thank you, Dr. Lakhani, for this wonderful elaborative lecture. And I think all of our delegates enjoyed your lecture. So thanks a lot. So we will take some questions at the end because we have some case presentations from distinguished faculties too. But I just want to welcome our distinguished panelists before. We have with us Professor Shantanu Kumar Tripathi, sir. So welcome, sir. I know all of us know Professor Shantanu Kumar Tripathi, sir. He's a very noted clinical pharmacologist in this country. So welcome, sir. Sir is also currently the president of Association of Clinical Pharmacologists. So a very welcome, Professor Shantanu Tripathi, sir. We also have with us Dr. Kaushik Vishwas. So Dr. Kaushik Vishwas is a very prominent figure in the field of endocrinology and diabetes management in India, especially in Kolkata. Dr. Vishwas had done his DM in endocrinology. So welcome, Dr. Vishwas. We have with us again a very prolific speaker, faculty in the field of endocrinology, Dr. Mohan Shenoy from Kerala. Dr. Mohan Shenoy is a very noted clinical endocrinologist. So welcome, Dr. Shenoy. And today we have 3 case presentation. For that, we have again distinguished faculties with us. We have with us Dr. Shaugato Sarkar. Dr. Shaugato Sarkar is a clinical pharmacologist at School of Tropical Medicine. Welcome, Dr. Sarkar. We have with us Dr. G.K. Sumed. Dr. Sumed is an DM resident of clinical pharmacology from Nizam Institute, Hyderabad. So welcome, Dr. Sumed. And we have again a very noted endocrinologist in this city, Dr. Silima Tarenia. So Dr. Silima Tarenia, welcome Dr. Silima Tarenia in this web podium. So we'll start first of all straight away to the cases, and after each cases, I shall request our esteemed panelist, and also if Dr. Lakhani will be there, so Dr. Lakhani also to give their insights also in these cases. So may I start with Dr. Shaugato Sarkar? So Dr. Sarkar, please.
I am audible clearly?
Yes, you are audible.
Okay. And now my slide is visible in full screen?
Yes, full screen. Yeah, please go ahead.
Thank you, Dr. Sambo, for your nice presentation. And Dr. Lakhani, your presentation was so nice and extensive. So we are just going directly to the case presentation. And you have already mentioned the all part about the adrenal insufficiency. It was a great learning session with you. Thank you for that. And thank you to API for giving me the opportunity for presenting the case here. And this is the first case presentation, the drug-induced adrenal insufficiency, the diagnosis that was primarily missed. Before going to this particular part, I just want to mention that we all know that when we are used steroid irrationally, even irrationally, in both cases, there are adrenal insufficiency. And for the tramadol, specifically, I am mentioning the tramadol here because my case is related to something related to the pain. So tramadol also have a huge potentiality to inhibit the HP axis, mostly the tertiary part. And here we can distinguish if this adrenal insufficiency is due to tramadol withdrawal or due to this steroid withdrawal or inappropriate steroid tapering by clinical presentation because the tramadol withdrawal symptom appear within 8 to 24 hours, and the patient usually present when this tramadol is used for long term. The patient usually present with anxiety, insomnia, irritability, craving, and there is different type of sweating, runny nose, then watering eye, diarrhea, etc. But for steroid withdrawal or steroid tapering inappropriately, these symptoms are usually not seen. And why I mentioned here, because my case is related to this, something related to the pain. So the my case presentation, the drug-induced adrenal insufficiency, the diagnosis that was primarily missed. Myself, Dr. Shaugato. This is a story of a woman of 56 years age. She presented to us 2 months back with extreme generalized weakness, anorexia, upper abdominal pain, nausea, and vomiting for last 20 days. And in this duration, she was admitted thrice in a BPSC, and they diagnosed it as a acid peptic disorder and investigated and treated for the same. And at the last part, due to inappropriate and inadequate improvement, patient do this under discharge under this bond and came to us. Her past history was unremarkable, except she was suffering from osteoarthritis both knee, and her previous report that was done during his BPSC visit was mostly unremarkable. Sodium was a little bit low. in one session, and then second report was absolutely normal, and just mentioned the lower part. USG whole abdomen, there was grade 1 fatty liver and epigastric tenderness. Upper GI endoscopy was performed. There was mild erosive gastritis and RAT was negative. Otherwise, all the report, that is pathological and biochemical report, were within normal limits. During her hospital visit, she was treated with oral or injectable drugs in different occasion and for different duration. And for the last 20 days, she was on PPI, oral, as well as IV in different time period. And along with she was on domperidone, antacid preparation, sucralfate, not associated with both two drugs, but in different occasions, she was treated with all these drugs. Ondansetron, antibiotics, mebendazole, dotaverine, ursodeoxycholic acid, and multivitamin. She was on rice tube feeding. We don't know why she was on rice tube, and she presented with this. And when we perform our general and systematic examination, we received that she was alert, conscious, cooperative. There was no pallor, clubbing, jaundice, edema, etc. Skin was a little bit pale. Pulse was a little bit at the higher side and BP at the lower side. Otherwise, all are unremarkable, except there was epigastric tenderness and generalized abdominal tenderness was noted, but there was no organomegaly. Now, we remembering she was suffering from the osteoarthritis. We solicited the detailed drug history, why and how he was treated for this for her pain due to osteoarthritis. We elicited that she was being treated for osteoarthritis knee till about 2.5 months before her first admission at the DPSC. And then, due to no improvement, she stopped her treatment. And this treatment was provided by an orthopedician. And then for the last 2.5 months, she was not under his care. One of her friends suggested her a medicine that had a miraculous effect, and she purchased the medicine from a garment shop. It was surprising, and after that, she began to take the medicine for at least 2 months, and that relieved him a greater extent. And according to the patient word, it's worked like a magic, and her pain and swelling was dramatically reduced. So this was the history we can elicit from her, and the medicine that is shown by her relative is this. This is only 30 rupees for this pack, and she was advised to take 1 tab each twice daily. And since last 2 years, she was on this drug, and her pain was relieved in a greater extent. Now, how we reach our provisional diagnosis? With the history, we get some light that the drug worked like a magic. It may be a glucocorticoid, or it may be a tramadol or opioid-like drug. But for the opioid-like drug, usually swelling is not decreased because it's not an anti-inflammatory agent. Pain obviously decreases. Mostly this can be a glucocorticoid or an NSAID of the high dose, inappropriate dose. So whatever it is, we assume it possibility there is a glucocorticoids. And in the last 2-month treatment, she has no abdominal pain. Now, if it is a glucocorticoid or NSAID in the higher dose, then there is a chance of upper abdominal symptom or gastritis if she is taken alone this type of NSAID or glucocorticoid. So second one, possibly was a PPI or H2 blocker. These are the possibilities. And the drug was unavailable for the last 3 weeks. And for that, she was on aceclofenac, what was previously advised by the orthopedician, but she took it infrequently because it was inadequate relief. And actually, her X-ray shows it was a grade 3, and it was advised by the orthopedician for total knee replacement. And during these 3 weeks, she gradually developed all these present symptoms with which the patient came to us. Now, this make our suspicion if the patient is possibly suffering from the adrenal insufficiency. If it is a chance of, if the drug, any of the drug was any tramadol or opioid-like drug, the problem, the withdrawal part will be initiated within days. But here it is gradually appear, and the patient's swelling diminished. So possibly there was some anti-inflammatory drug, maybe glucocorticoid or maybe NSAID. Now we started the treatment and we inject a hydrocortisone 100 mg and asked the patient to get readmitted. But she and her relatives refused it strongly. She was advised for morning cortisol at 8 a.m., ACTH, CBC, and all these tests. And the next day, she was advised for hydrocortisone 15 mg IV for 4 times. And the dose should be taken after the blood is given. The hydrocortisone dose was given around 11 a.m. when the patient was presented to us. Her report received as cortisol was 0.7 mcg per dl. It was clearly low, and there is a clear suppression of the adrenal gland. ACTH also is the less than 20, so high possibility this is due to the drug induced and possibly maybe due to corticosteroid. The SST and other dynamic test was not available locally, and we also referred the patient to endocrinologist as well as orthopedician, and we switched the treatment to hydrocortisone 10 mg after breakfast and 5 mg between 4 to 5 p.m. and PPI was continued. And the outcome after 7 days, there was a huge clinical improvement. Patient do not complain any problem further. And after 1 month, the evening dose was withheld and repeat cortisol estimation was done at the next morning, and it was 1.39. There is a little bit increasing. And then the dose of hydrocortisone was reduced by 2.5 mg in both occasions, that is morning as well as in the evening. And she again requested to have an opinion from the endocrinologist. Till the last knowledge, the patient do not have any complaint and patient is on the drug, but till now patient is not reported to us. In conclusion, that Dr. Lakhani also said that particular word, the detailed drug history should be taken. And if we listen to our patient, actually patient is telling the diagnosis. This is a great word from Sir William Osler. So detailed drug history is always essential for right clinical decision making. Drug-induced disease should always be a differential diagnosis by default. We should have a detailed drug history and assume that if any clinical symptom that is presented to us is due to any drug or not. If it is yes, then we should reconcile the patient at that moment. And by simple test, we can detect if the drug the patient is consuming has steroid in any chance. That is Lieberman-Bouchard test and Saluas reaction. But we do not perform in our setting. This is a very easy test we can perform in our small lab or even in our clinic too. 1 ml of aqueous solution of the drug, then add 10 ml of chloroform, then slow drip of 10 ml sulfuric acid. The upper layer will turn red and sulfuric acid layer will turn yellow green. If it is, then the drug contains steroid. So by this simple method, we can detect if any drug that patient is consuming for confirmation that patient has, the steroid or not. So with this, thank you. Thank you.
Thank you, Dr. Shougata Sarkar, for this wonderful case presentation. And I think here I want to mention one very interesting study conducted by Gupta et al., which was published, which had found that 38% of their research products, the products they had done this research, of around 120 herbal and Indian alternative remedies that contain dexamethasone at various doses. So this is really something concerning for us, especially who are treating day-to-day patients, and we need to be very much vigilant while seeing this type of presentation. So at the onset, we have with us Professor Shantanu Kumar Tripathi, sir. May I ask sir to tell his approach towards drug-induced disorders? I think Dr. Shogato Sarkar had also mentioned in his concluding slide to make drug-induced disorders always in our differential diagnosis list, because that can help us a lot to detect the original problem. So may I request Professor Shantanu Kumar Tripathi, sir, to say some important insights about this drug-induced disorder evaluation.
Hello, am
Yes.
I audible?
Yes, sir. Yes, sir.
Okay. So good evening, everybody, and thank you for this wonderful opportunity of learning. And the first lecture was wonderful by Dr. Lakhani, and then we also have listened to the small case report, and it's very it's very interesting that we are gradually trying to understand, trying to appreciate that yes, it is also drug-induced disorders are also to be taken with all due seriousness. And if we become very systematic in our approach to patients, keeping always in mind that it could be a possible diagnosis, drug-induced problems, drug-induced disorder, and take this as a legitimate differential diagnosis, and we need to then exclude it, rule out this, whatever problem the patient is presenting with, it's not being caused by any medication that the patient is consuming currently or in the recent past. And for that, there is a simple rule, we call it in diagnosis, in clinical diagnosis, always try to rule in and try to rule out then. Rule in and rule out. So you can only rule out a possibility only when you have ruled it in. So for ruling it in, you should have it in mind. You should learn to suspect it. And for suspecting that it could also be possibly caused by a drug, then it becomes very otherwise very suggestive that you have to take a detailed medication history. What are the medicines the patient is currently taking? What are the medicines the patient were taking in the very recent past? Because as we know that the patient may not only present with the impact of a drug in the form of a undesirable undesired effect, that may be an extension of its pharmacological actions, or it could also be type B kind of adverse effects of the drug, de novo, or that can be also be caused by possible adverse drug-drug interactions or even drug-food interactions, or sometimes it may be the presentation could be also because of recent withdrawal, abrupt withdrawal of a drug, and basically what you are looking at is actually withdrawal syndrome, and that is causing problem in the patient. So when you talk of adrenal insufficiency in this instant case that has been presented very nicely by Dr. Shogato, the adrenal insufficiency that has been otherwise experienced in this patient, and patient has presented with features of manifestations of that, clinical manifestations of that. but only when the possibility of missing this kind of reaction is also certainly it was not a prescribed medicine uh, the way we understand prescribed medicines in modern medicine. So if we ask the patient what are the medicines you are taking, he may, in the first go, he might not be telling you about this medicine, what Dr. Shogoto has found out. So I like that slide where he mentioned that solicited, okay, his medication history, eliciting medication history. That means you have to probe a little. You have to also ask that, are these the only medicines that you are taking? Or not necessarily your eliciting medication history be limited to the medicines that are prescribed by modern medicine practitioners, so-called allopath practitioners. The patient in Indian context, particularly because we are practicing multiple systems, or from the patient's perspective, patient is coming to you, you are a modern medicine practitioner, but then at the same time, the patient is also consulting his Ayurvedic physician or a homeopathy physician. So like that. So you need to ask everything, whatever the patient is taking as medicines. In this case, like the medicine that was being shown, even now it is on the screen, it's clear that there is no level. And it is clear that it has been uh, fabricated, or it has been prepared very locally, maybe in a household, okay? Uh, and the maybe the practitioner himself has developed or manufactured these, okay? And even it is interesting that the size and shape of the pills are not also similar, okay? That itself will arouse suspicion, okay, about the genuinity of the medicines. And in this kind of practice, it is very likely that corticosteroids are added in order to get prompt response. Although many a times they would claim that it is of herbal origin, but then it is very, very highly possible that synthetic corticosteroids, okay, they are actually added to this. Now, many a times uh, the taste that Dr. Shogoto was referring to, this is basically a qualitative color taste by which you can identify the presence of steroid in the sample. Okay, but then again, somebody might argue this is not a quantitative taste, this is a qualitative taste, the color reaction. So, but somebody might argue that even the many of the herbs, they also have phytosteroids, and it uh, might not be containing actually the synthetic steroids like glucocorticoid or prednisolone, might not be mixed with that. It is the phytosteroid that is giving this color reaction. That may be true also, yes. But usually it is said that the presence of phytosteroid in the amount that is there, that is unlikely to cause these kind of uh, adrenal suppression and the adrenal insufficiency, HPA axis suppression. So whenever we find this kind of situation is happening, it is almost always it is likely that externally these kind of synthetic corticosteroids have been mixed with them, and they are providing this. This is about this specific case. What is my comment? But then, in general, whenever we talk of not necessarily drug-induced adrenal insufficiency, in general, for the approach for diagnosing drug-induced disorder, particularly when long-term intake of different drugs are happening, okay? So, particularly for prolonged intake of oral medications, so there one needs to carefully look into the how the manifestations are, okay, presented, the nature of the presentation, and then if there is the what they are responding to. But like in this case, what Dr. Shogoto had mentioned, the actual this thing had come when you find that for some time the patient was not taking these medications that they have shown. So these kind of, while by studying these situations, one can also strengthen the suspicion. The key word here is gradually try to learn how to suspect this, and keeping in mind always that drugs can cause problems, as has been very nicely mentioned uh, by the first speaker, Dr. Lakhani, that like candle, drugs are like candle. This is a very good analogy. That candle provides light, but at the same time, candles can cause it can catch fire. So it's up to the person who is holding that candle and how carefully he is placing that. So, and so long you need the light, the candle will keep on giving you light. When you don't need it, take care and you put off the candle. Otherwise, there is a likelihood that it can. So there, in case of medicines also, that's why we said that handle the medicines with care and use the medicines wisely. And that wisdom has to come through your intellect, through your understanding about its pharmacology, its pharmacodynamics, and its risks associated with, and also the different drugs that are taken simultaneously, what are their potential adverse drug-drug interaction risk along with that, and also drug and food interactions, etc., etc. And don't forget about the potential for causing adverse effects when you suddenly withdraw it. What can happen with steroids? What can happen with the beta blockers, etc. So the key to success for diagnosing drug-induced disorder is considering drug-induced drugs as a very, very serious etiology for causing problem, considering drug-induced disorder as a differential diagnosis that must not be missed out. Always keep that in the list of the differential diagnosis. I would say that always should remain as a constant differential diagnosis in all clinical cases. Okay, any patient who is coming to you, you have to keep in mind there is a possibility of drug-induced problem, and so first I have to rule that out, and I can only rule that out when I keep that in my differential diagnosis list. So I can, for the time being, I would comment this much, and if necessary, we can discuss it further. Thank you.
Thank you. Thank you very much, sir. As we are running short of time and we need to move forward, I will request Dr. Shenoy and Dr. Kaushik Vishwas to have their comment at the end, because we'll take the cases from Dr. Sumed first. Dr. G.K. Sumed from Nizam Institute. So welcome, Dr. Sumed. He is a DM resident of clinical pharmacology at Nizam Institute of Medical Science, Hyderabad. So will you start your presentation?
Yes, sir. One second. Yeah, is it visible, my screen?
Yeah. Please make it full screen.
Yeah. Okay. Good evening, everyone. Myself, I'm Dr. G.K. Subed, first year DM resident. And firstly, I'd thank the organizers for giving me this opportunity. And under the guidance of Dr. P. Usharani, a senior professor and HOD, Department of Clinical Pharmacology and Therapeutics, NIMS, I present my case. But before starting the case, I would like to say that my case also revolves around herbal medications. And as discussed by Dr. Professor Tripathi sir and Dr. Shambhu, this recent report also shows that almost every second individual in our country uses herbal medications in both the rural and urban backgrounds. And by this background information, I start this case. This case was this is a 55-year-old female who came to Department of Orthopedics with chief complaints of joint pains and difficulty in walking. And on workup, she was diagnosed as having osteoarthritis, and she also had a history of tender Achilles tear with hematoma, and no other comorbidities were seen, but and was due for surgery. And during the workup for surgery, she was seen that she was having increased TSH levels, and in view of that, she was referred to NIMS endocrinology department. And the endocrinology department at NIMS, they have seen that the history of presenting illness was that there was joint pains, and also there was mild puffiness of face, and no special or no history of weight gain was seen. But in the past history, they have seen that there was alternative medication use, and she was using this alternative medication since 1 year for the pain relief, and also she attained menopause 8 years back. On examination, she was found to have cushingoid facies, but no striae were noted. Vitals were all stable, and systemic examination also did not reveal much. And the endocrinology department at NIPS, they advised to go for serum cortisol and HbA1c levels. And also the patient was started on tablet thyroxine, 25 microgram once daily for the increased TSH levels. As we can see that here in the baseline reports, nothing much significant except for serum TSH, which was raised a bit. On the next visit, the patient came with the reports of serum cortisol, which was found to be very below, significantly less. It was less than 0.5. And on proper history taking, they have seen that there was alternative medication use for osteoarthritic pain. So she was referred to clinical pharmacology OPD, suspecting a drug-related adrenal insufficiency. And in view of surgery, the endocrinology department also advised tablet hydrocortisone, 10 milligram BD, in case of future stress-related things. And the review at the Clinical Therapeutic Services OPD, which is presently going on in NIMS. It is like thrice a week. And at our OPD, we have seen that during the review, after thorough drug evaluation, whatever the drugs she is taking on, we have seen that she was on herbal medications, these medications, which you can see on this picture, along with tablet aceclofenac, 100 milligrams, SOS for pain relief. And the detailed drug history revealed that there was no possible abuse of other possible abuse of steroids. So the herbal medications which she was on were like 5 different type of syrups or capsules or tablets were there, and she was taking at these doses actually, like 10 ml or a capsule a day or tablet a day, and she was consuming almost every day. And on looking at the ingredients which were present, we can see that this is an exhaustive list, and it was like more than 25 ingredients. So we had searched for each ingredient which might be causing adrenal insufficiency, or whether they have seen any, although we have seen any published literature on adrenal insufficiency of these ingredients. And among these, we have also seen that the highest amount which is, the patient was on is that it was with ashwagandha. It was around present in almost 3 or 4 the herbal medications, and the dose was approximately 1 gram per day. Other common ingredients which were present were like Tribulus terrestris, which was around 400 milligram per day, Asparagus racemosus, which was around 300 milligram per day, and Terminalia shabula, which was it was like 300 milligram per day. These were the most common ingredients which were reoccurring in all these medications. So we have, after a literature search, we only got a single case report of adrenal hypofunction with Lithania somnifera. This was recently published, and other ingredients we could not find any published literature showing an association with adrenal hypofunction. So we reported an ADR, and causality assessment was done. According to WHO scale, we could possibly say that these abnormal serum cortisol values might be due to the drug intake, and these drug intake values show reasonable time relationship. Hence, we can possibly attribute this scenario to the drugs. And we have advised from our side that the patient to stop all the alternative drugs. And we handed it over to the endocrinology department. But on the next visits too at the endocrinology department, we can see that serum cortisol values were significantly low on both the occasions. Like she came on April of 2nd April and also on 24th April. On both the times, you can see that serum cortisol was very low. On both occasions, we had counseled the patient well and all the attendants to also to stop the medication, but the patient was like, she continued these medications for pain relief. And on the 24th of April, we also, the endocrinology department also advised for ACTH stimulation test. On ACTH stimulation also, we can see that there was not much increase in serum cortisol values, and we can confirm that there was significant adrenal insufficiency. Plasma ACTH did not reveal much actually. It was around 49 picogram. So this we can say this is a case of exogenous Cushing's with adrenal insufficiency, secondary to usage of these chronic herbal medications, and also for both the chronic intake or more than 1 year of herbal medication usage was seen. Also, patient is diagnosed as de novo hypothyroid and is also a pre-diabetic. So the patient was advised to follow up for appropriate management till normalization of adrenal axis with the Department of Endocrinology and Orthopedics for pain management. But the patient hasn't turned up, so we could not follow up the the proper cortisol values of which are was there. But this is one of the problems at the tertiary center. So sometimes we cannot fill the complete information. This case report, which I was saying that this was published by Christopher H. Fry, and it was published in Toxicology and Environmental Health Sciences Journal, where they have seen that a patient of similar age, like 50 years, she had chronic fatigue, and also she was having myalgia. So in an advertisement, she was a resident of United Kingdom. In an advertisement, she saw that this usage of ashwagandha powder might improve her symptoms. So she started using this ashwagandha powder, and after that, when she came for routine checkup, she was seen that there was very low cortisol values, and she was assessed using short synactin test during and after treatment with ashwagandha. So while taking this ashwagandha supplement at around 960 milligrams for 10 weeks, it showed like a very minimal response to this synactin or tetracoxactine, and the values were like less than 328 at 60 minutes. And also, we can see that after that, she was counseled to stop the tablets or powder. And after 2 weeks, the repeat SST was done, and they showed that after 2 weeks, the cortisol levels were much better. It was more than 674 nanomole per liter. So they concluded that this 10-week of ashwagandha supplementation was associated with adrenal hypofunction, which was reversible after 2-week break, with the repeat SST showing a completely normal adrenal function. So in this report, or case, we can also possibly attribute this deficiency of adrenal deficiency to the steroidal compounds from ashwagandha, such as bethanoids and alkaloids, which may have a direct effect on adrenal function. Recently, a study also showed that DNA damage might also be seen, and an animal study also showed that there is a weight reduction with adrenals if given for continuously for a few days. So the take-home point or message from this presentation is that future studies are needed, and also we have to be a bit more vigilant in cases of these herbal preparations. Thank you.
Thank you, Dr. Shumed. And I think this is a very interesting case we will discuss.
Yeah, a small bit. I also want to acknowledge the organizing committee firstly, and also our senior professor and HOD, Dr. P. Usharani, and also the Department of Endocrinology, which were quite helpful. Dr. Beatrice Anne, she's the professor and HOD of Department of Endocrinology NIMS, and also Dr. Sumana Kunuru, associate professor, and also Dr. Bhavani, and my faculty and colleagues for that. Sorry for that.
Thank you. Thank you. A special thanks to Dr. Usharani madam and Dr. Bhavani madam. Thank you. So
Yeah,
from side also. So I am requesting you to stay with us, because there will be some questions to you also for further discussion. And we will now invite Dr. Silima Tarenia, who is a very noted endocrinologist from Kolkata, currently faculty at Medical College, Kolkata at the Department of Endocrinology. So welcome, Dr. Silima. So can you please share the slides? So I'm requesting Dr. Shumet to please unshare now so that.
Yeah.
Yeah. Can you please unshare, Dr. Shumet?
Yeah, it's gone, no?
Yeah, now perfect. So may I request Dr. Silima, so please share the screen.
Shambho, can you just help me out?
So if you have any problem, then I can request Dr. From Clarnet. I think you had the slides of Dr. Silima.
Yeah, yeah.
Can you please share that? Team Clarnet, can you hear us? Would you please try once, Dr. Silima?
Yeah, yeah. Just tell me how to go about it.
Below there is a share option. You can.
I've clicked share screen.
Yes.
Now, what do I click on?
You will getting some option. You will get that PPT option. Yes, your screen is shared.
Oh, it's shared. Okay.
Yeah. So you can go to the first.
Shall I click stop sharing?
No, no, no. You go to the first slide. Yes. And make it full screen.
So just a moment.
Just be sorry. Yeah. Make it full screen.
Okay. So is that fine?
No, it is not coming. So one thing you can do not panic. Just click on the stop share option. Above there is a stop share. Yeah. Now again start share. Click on the share option.
Is it visible?
It is not visible in complete slides. So you can start it. I think if you are not making it full screen, you can start.
Is it in full now?
No, no, no. You better you minimize that so that we can see your other slides also. So minimize your. Yes, just.
Can you see any slide at least? Can you see the first slide?
We can see. Now you just change your slides without making it full screen.
Yeah, Dr. Shirima, you can try pressing shift and F5 together.
Okay, so is it shifting? Like, I think now I'm pressed on my first slide. Is it showing?
Yes, yes.
Yeah, you're showing, but it's not in full screen. So what you can do is, on the top, you can see slideshow, right?
Slide
on the top.
show.
On the top of the PowerPoint.
Yeah, no, it's not on the top. It's on the slide. It's on the side. I've clicked that, but when I'm clicking, it's
no. Okay. Go on the top. There is file, home, insert, draw. Right? You can see that.
Just a moment. I'll just stop sharing, I think. And
no. Okay. Share. You don't have to stop sharing. Share again.
Just a second. Share screen. Window. Share. I don't know. I think should I just do it?
Okay. No. Just try once. Press on shift and press on F5.
Shift and F5.
Yeah.
Okay. Yeah, I did that.
Yeah, just give it 1 second.
There's some issue, I think, so with this, right? Because I did that, it's showing the same thing which showed when I clicked on.
Okay.
You can go with that.
Okay, fine. You can go ahead. You can go ahead. We can see it anyways.
Okay, fine. So, should I press escape or should I just continue this way?
No. Escape.
Is it fine now?
Yes. Now you can go to the case one. No problem.
Yeah. Okay. So, very good evening, everyone. At the very outset, I would like to thank API and the Clinical Pharmacology Subcommittee and Dr. Shambhu for giving me the invitation. So, as the previous speakers have already discussed in great details regarding every aspect of adrenal insufficiency due to drugs, covering almost the entire spectrum, starting from drugs to as well as herbal and alternative medications. So my case would be almost kind of a little summary of whatever has been discussed, especially what Dr. Lakhani has explained in details. It would be in the form of a small little format. So I would be starting with my case. A 40-year-old female presented to us with fatigue, anorexia, weakness, nausea, and few episodes of vomiting for the last 2 weeks. On further inquiry, it was found that she is having some over-the-counter medications for pain for the past few years, which she has stopped in the last 3 weeks. On examination, I'll directly go to the picture. So these figures have been taken from the web only for reference purpose. In the first one, we can see that the faces are flushed and there's kind of a Cushingoid faces, there is a round face. This particular patient also is having hypertrichosis, that is little baby hairs we can see, which is all over the forehead, especially on the temporal side. She also had buffalo hump, that is supraclavicular, dorsal-cervical pad of fat was positive. We can also see these stria over here, which are white and purple. And apart from this, she also had proximal myopathy. So just like my previous speakers have already discussed, the moment we come across a scenario like this, we are supposed to think it can be a case of hypercortisolemia, both exogenous or endogenous. So the first thing that should come to our mind is to go for an 8 a.m. cortisol. On further probing, it was found that she was on tablet prednisolone 20 mg for the last 2 years and has stopped it recently. So this is our investigation. The cortisol comes to around 2.3 microgram per dl. So just like Dr. Lakhani had mentioned that there are few different cutoffs. When the cortisol level in such a background is less than 5 microgram per dl, and in some studies they claim it to be 3.5 microgram per dl, it is an indicator that the hypothalamic pituitary adrenal axis has been suppressed due to exogenous glucocorticoid. So that is one point that we gather. Secondly, coming to the ACTH, just like Dr. Lakhani had previously discussed, that in primary adrenal insufficiency, we have a low cortisol with a background of a high ACTH, usually greater than 100. In a secondary or a central adrenal insufficiency, we get a low cortisol with an ACTH, which can be either in the low normal range or inappropriately normal. Last but not least is the sodium. So because this is a case of secondary or rather central adrenal insufficiency, where the mineralocorticoid axis is spared, the sodium is slightly low. This is probably because of the effect of AVP, where the free water clearance, which was previously there, that has been removed due to water retention. There is some amount of dilutional hyponatremia. So at this point of time, we're quite clear that we're dealing with a case of adrenal insufficiency, a central one. So what is to be done, whether to replace or not to replace? So whenever, this has also been previously discussed, that whenever a patient is on a therapeutic dose of glucocorticoids and the disease has not yet been controlled, we do not have to do much over there. We need to wait till the disease is either cured or it is sorted. Once that has been achieved, then starts the object of tapering the drugs. So for that, here there are just two definitions I've put up over here, which we've encountered in, which we've seen in our guidelines of the latest ones. If the duration of glucocorticoid therapy is greater than 3 to 4 weeks or greater, that poses a risk for adrenal insufficiency. And if the dose of the glucocorticoid therapy is greater than the daily hydrocortisone equivalent or equivalent to the others, that is a hydrocortisone dose of 15 to 25 mg, 4 to 6 mg of prednisolone, then that is also going to cause the patient to suffer from adrenal insufficiency. So in our patient, if we look back, she was on glucocorticoids for the last 2 years and with a dose of 20 milligrams. So it's most likely that she is having adrenal insufficiency and we need to start tapering the dose instead of sudden abrupt withdrawal. Whenever a patient is on glucocorticoids for about lesser than 2 to 3 weeks, we might assume that the hypothalamic pituitary axis is not suppressed and we might as well abruptly stop. But if the glucocorticoid is continued for a period greater than 3 to 4 weeks, then we need to go for a taper. So the tapering has already been discussed. For our patient, what did we do? She was on 20 milligram of prednisolone. So we brought it down by 5 mg every week. So first from 20 mg in the second week, we made it 15. In the third week, it was 10. And then last week, it was 5. So once it came down to 5 mg, we had two options with us. Either to reduce it by 1 mg every 4 weeks or to convert it to a physiological steroid like hydrocortisone at a physiological dose. So in our patient, we started the patient on hydrocortisone 10 mg at 6 a.m. and 5 mg at 4 p.m. After the prednisolone physiological taper was brought down to 5 mg 5 mg. So now I have just kept one slide to show regarding the risk factors for developing adrenal insufficiency depending upon the glucocorticoid potency. So this is also to be kept in mind that hydrocortisone, deflazacort, these have lesser potency for crisis. But whereas dexamethasone, betamethasone, these are very, very potent steroids and they have a very high risk of developing withdrawal symptoms or crisis, and prednisone, prednisolone being the moderate ones. Now coming back to our patient. So 6 months later, we repeat a cortisol. Now what is needed to be kept in mind is that the hydrocortisone what the patient was on, the previous evening dose and the morning dose had to be omitted before doing the test because hydrocortisone has a tendency to interfere in the assays. Our cortisol comes to 7 microgram per day. So we'll be seeing in the subsequent slides that if the basal cortisol is greater than 10, we can roughly assume that the axis has recovered and we can go to stop the steroids. But here we got a cortisol of 7 microgram per DL. So what is to be done in this situation? We had to go for a synactin stimulation test. Already Dr. Lakhani has described in detail how to go about a test. We need to push a 250 microgram of synthetic ACTH IV and to take in cortisol at 30 minutes and at 1 hour. If the value does not cross 18 microgram per DL, this indicates adrenal insufficiency. So here again, there is a caveat. Basically, this particular test, synactin stimulation test, has a 95% specificity, but the sensitivity is not that great. So this means if a patient is not being able to cross 18 microgram per DL, so there is a very strong likelihood that the axis has not yet recovered. But if the patient is crossing 18 microgram per DL, there still might be a chance that the axis has not recovered and we are falsely getting it. So that has to be kept in mind while interpreting. So I have just kept this pictorial from the guideline itself. So when patients who are receiving supraphysiologic glucocorticoid doses and at high risk of adrenal insufficiency, slowly when we are bringing it down to the tapering doses and we are giving them, say, a hydrocortisone 10 mg and 5 mg, what do we need to do? Especially in the setting that I'm discussing about, that after 6 months, the random cortisol 8M comes to 7. So here is the graph. If the baseline is less than 5 microgram per DL, then we need to continue the glucocorticoid replacement and again repeat the same after 3 to 6 months. If the baseline is greater than 10 microgram per DL, we can jolly well stop the glucocorticoid replacement. If the value is between 5 to 10, that is in our case where we got 7 microgram per DL, we need to run a post-synactin stimulation test value. Depending on whether it is crossing 18 microgram per DL or not, we need to take a decision accordingly. Coming to DHEAS, this too has been discussed previously. So this is again another surrogate marker to help us identify whether the axis has recovered or not. So what we need to keep in mind here again, we have a point to be noted is that if the DHEAS is in the normal range, we can say that the axis has recovered. But if it is not in the normal range, we cannot actually say that the axis is still suppressed because the DHEAS also takes a lot of time to completely come back to normal. So in our case, the cortisol post-synactin stimulation test was greater than 18 microgram per DL and we could stop steroids in that patient. Now, I have just kept another little nugget regarding immune checkpoint inhibitors related adrenal insufficiency. So most commonly that is the ipilimumab. We also have nivolumab, etc. So one of the common side effects of these immune checkpoint inhibitors is hypophysitis. And the incidence of hypophysitis is more seen in combination drugs than when these drugs are used alone. And another important fact to note here is that these are more common in men, contrary to the lymphocytic hypophysitis, which we find more commonly in women of either childbearing age or in the postpartum. When does this present? Mostly these immune checkpoint inhibitor related hypophysitis, it takes weeks to months, though there is no definite time period, but majority of these studies claim that usually it's within weeks to months. And the symptoms may range for something very, very non-specific like headache, tiredness, malaise, fatigue, etc. Again, mass effect is rare because usually the size of the pituitary is not that large to cause a compression at the chiasma or nearby. So we rarely get any mass effects. What is to be noted is that two of the important things that happen here is a central adrenal insufficiency and a central hypothyroid. I'm just mentioning the central hypothyroid because usually both of these go hand in hand in a patient of hypophysitis due to immune checkpoint inhibitor therapy. Now, the central adrenal insufficiency is definitely responsible for a major morbidity as well as mortality if the steroids are not promptly given to the patients. Sometimes it might even be life-threatening. Now, usually we need to run in a cortisol or a cosentropin test for interpretation of whether the axis is suppressed or not. But what problems we face in this background is if a patient is having a recent onset adrenal insufficiency, central adrenal insufficiency, the cosentropin stimulation test might be falsely showing high cortisol levels because the adrenals have not got enough time to atrophy. So that is why in this kind of a background, we need to look at what is happening around us. The clinical context is relevant. And also, if required, depending upon the situation, empirical glucocorticoids are to be started to save the life of the patient. Central hypothyroidism can be associated with it. So that needs to be kept in mind here. And usually for treatment, because the recovery from the central adrenal insufficiency is rare, so either we start with a replacement dose of steroid if the patient is stable, but if the patient is having severe hyponatremia, critical illness, or due to some reason there has been a substantial mass effect, high dose steroids are reserved in such situations. Now, this is my last slide. Coming to primary adrenal insufficiency, this is again related to immune checkpoint inhibitors. This has been very, very rarely reported because most of these immune checkpoint inhibitors cause secondary adrenal insufficiency, central adrenal insufficiency. So in this case, if there is adrenal crisis, like has been mentioned previously, there'll be both mineralocorticoid and glucocorticoid deficiency. There'll be low cortisol with a background of elevated ACTH. There'll be profound hyponatremia, and the management would require replacement of both glucocorticoids and mineralocorticoids. Thank you so much for your patient hearing.
Thank you, Dr. Silima, for this enlightening talk. And I think very important two cases you had shown. Now I am requesting our esteemed panelist. First, let's start with Dr. Mohan Shenoy. So please let us know your input from the second case first, and then we are going to discuss about this third case.
Yeah. So thank you, Sambudha, and all the team for having me here. So before going to the case, I think a very good program and very bold statements have been made because regarding herbal medicines and over-the-counter medicines, whichever the patient is taking, you should be cautious. Actually, Endocrine Society of India, under the ages of a lot of youngsters, I think I was a young that time, we actually had an endocrine brigade. Okay. So we actually had a cartoon. We made cartoon series. We made patient information videos. For the last 3-4 years, we are doing it. Recently, we are bit less doing it, but I think this really calls for action because when the Ayurveda or other stream of medicines are blaming us for doing rational medicine and telling side effects exist, the same vein we should also remember that we should tell that our strengths are definitely not your strength. We do research, so that is what I think. This all the cases have been done. Dr. Silima had presented very nicely, a very good approach to getting this what you call correct testing. So I just wanted to know generally from the pharmacology scientist here. So how do you do in the lab? Do you have a toxicology association? Because I worked in Amrita where we had Dr. Bhaskar Pillai. He's setting a largest South Indian center for collecting all the medicine intake, all those suspicious inhalers medicine for Ayurveda, those who were taking. No, they usually isolated the steroid in those specimens. So do you have specific reference centers in your place which you do? That is one question. And second observation is that how long do you have to give steroids in these cases?
Yeah, so actually the thing is that when we talk about steroid, whether that is present or not, we have this facility of checking through some qualitative test. And I think Dr. Sarkar had mentioned
Yes.
that test, that methodology. So we had one lab technician, and generally I can share with you one
Yeah.
of
Can anybody send the samples to your side, or is it
yes,
specifically?
yes. Anybody can send, and I think this is a very easy chemical test, and I think this can be done in our OPD setting also.
Okay.
So one day we can have, later we can plan for a
So that
small
means that
workshop,
we can collaborate and we can make the reference standards and labs. And according to that, because Hyderabad also we have some experience, we had sent a few samples for whichever the Amrita could not do. We used to send in some other center, I think some IIMB or some center there, reference center. I don't know, some reference lab was there. So that was good. And how long do you want to give these steroids to those patients? So do you think such patients can be tapered off the physiological steroids, or how long, which is the longest duration that you have given for a patient of this?
Sir, for which particular patients
No,
are you
particular name, just I'm telling you, you are also experienced in such cases. So what is the longest duration you have given for a patient of this sort of patient?
Yes. So mostly I think from 6 months to 9 months at least it is needed. Rather, I have rarely seen any patient where I have been able to taper it off within say 1 or 2 months. It becomes very difficult. Mostly at least 4 to 6 months. And since I'm working in a cancer setup, sometimes we get patients who have completely even primary adrenal insufficiency. In those cases, for instance, sir, it's a case of a tuberculosis. Say it's an adrenal TB. I have never, rather probably in last 3 to 4 years, I've not seen a adrenal TB case recovering. Now, I don't know whether probably it's due to permanent adrenal atrophy, but in case of a glucocorticoid induced adrenal insufficiency, at least 6 to 9 months, sir, I think in my opinion, I have faced.
Yeah, there's also psychological factor also. Some people feel that's also one of the things. Dr. Om, anything to
Dr.
add?
Mohan, it could take months and years also for HP axis to recover. It depends on, again, the age of the patient, the glucocorticoid exposure. And what you said is very right. In fact, if you see the recent guidelines also, in fact, this is a slide which I wanted to put somehow, I kind of missed it. There are two terminologies. One is glucocorticoid withdrawal syndrome, and second is, adrenal insufficiency. Both are separate entities. So the glucocorticoid withdrawal syndrome is where, you have a sort of a mixture of psychological factors, some mild adrenal insufficiency features, and also, the underlying disease itself. Sometimes we have some underlying disease which can kind of flare up after the steroids are being withdrawn. So this glucocorticoid withdrawal syndrome is a condition where there's a lot of psychological component the patient really feels, and then patient tends to go back to the steroids themselves.
Yes.
Like you saw, I think all these cases, particularly, I think it was probably the second or third case, where the patient just refused to stop the alternative medication, even though there was clear evidence that there was, a damage being done. So I think that also tends to happen. So there is a psychological dependence, especially to dexamethasone. I think that has been very nasty to produce a, sort of psychological dependence as well. So I think it's a big problem.
Dr. Kaushik, you can take over. Kaushik, you can discuss the other case. I think we have interactive crowd. Are you there, Dr. Kaushik? Yeah. Please. Can you discuss the case of Dr.
Kaushikda, you're mute. I think you're mute, Kaushikda.
Yeah, that is right. Yeah, sir. Yeah,
Sorry,
please.
yeah.
Maybe you can discuss. Yeah.
You have discussed a lot about that. I think nothing much to add.
Yeah.
We can move ahead.
Yeah.
Any more cases are there? Do you have any more cases?
I think Dr. Kaushik Vishwas is also attached with one of the very large oncology setup. And I think nowadays we are using a lot of CTLA4 inhibitors and PD-1. So what is your experience on that?
See, these immunomodulators are really a problem. Why lots of we have a big oncology setup, and nowadays very frequently we are getting patients with the adrenocortical insufficiency because of those immunomodulator drugs, especially anti-CTLA4 monoclonal antibodies, and sometimes PD-1 anti-PD-1 antibodies also. So the problem is that we need to, along with that, we need to be while they are present, the awareness has to be there, and the suspicion has to be there, because a cancer patient with metastasis to adrenal gland can also present with primary adrenal insufficiency, and there are many other things which can culminate into adrenal insufficiency. So I think the heightened awareness about the uh, uh, possibility of primary adrenal insufficiency with those immunomodulator drugs are very important. And a high index of suspicion is necessary because often after surgery or after receiving chemotherapies, many of them ultimately land up into the, intensive care unit. And they often developed, they are great mimickers like hypotension and other things, and they might not be responsive if we do not objectively look for the adrenal function, or at least we suspect it. So yeah, we are gradually developing that knowledges also.
Yeah, thank you, Kaushikda. And I think what is your general approach? Because sometimes we need to also check whether, especially when the patients are taking this type of drugs, not always they contain steroid properties like traditional drugs, but patient presents with features of adrenal insufficiency. So basic steps, just for a quick recap for our delegates, that how we should advise our patient to rule out drug induced, or it is something primary.
So I always start, as in other cases, always start with, we should start with the history and examination. I think still history is very important while dealing with a case of adrenal insufficiency. Usually primary, if first of all, we can, many of the cases, we can rule out the drug-induced cases. And when there is no discernible causes of drug history, we should look into the primary causes. And there are some clinical pointers, like primary adrenal insufficiency. Primary may present with, the adrenal crisis. Adrenal crisis is more common with primary adrenal insufficiency than the secondary adrenal insufficiency or tertiary adrenal insufficiency. Similarly, development of hypotension, hyponatremia, hyperkalemia are more indicative of clinical clues of of primary adrenal insufficiency than secondary adrenal insufficiency. On the other hand, when there is a history of hypoglycemia, that can be in favor of secondary adrenal insufficiency, when in addition to hypothalamo-pituitary adrenal axis, the growth hormone axis and the other axis can be lost because of the pituitary or hypothalamic problem. And other clinical, very important clinical clues could be pigmentation, especially the pigmentation of the sun-exposed areas, the pressure areas, the nipple, the hand creases, and especially this new pigmentation of the scars can be indicative of primary adrenal insufficiency because of the action of elevated ACTH on melanocortin-1 receptors. Similarly, presence of other autoimmune stigmata like vitiligo or other autoimmune diseases, type 1 diabetes mellitus, or most commonly primary hypothyroidism, can be a clinical pointers towards primary adrenal insufficiency, not the secondary adrenal insufficiency. Similarly, if you look at the general lab parameters, not the diagnostic, general lab parameters, there we can also find the clue like the electrolyte imbalance are more common, and the non-anion gap metabolic acidosis is mainly seen in primary adrenal insufficiency, not in secondary adrenal insufficiency. Similarly, a simple clinical clue like often adrenal insufficiency is a mimicker of a great mimicker. Often patient present with symptoms like gastroenteritis, and often we send a blood sample of liver function test. And if liver function test be found to be abnormal, it could be a indicative of autoimmune hepatitis, which is more likely to be associated with primary adrenal insufficiency. So always look into the basic data. If you look into the basic data, there will be always be some clinical pointers which can lead us to or channelize to a more specific pathways. And of course, there will be diagnostic approaches to differentiate among primary and secondary adrenal insufficiency. Thank you.
Thank you. This clinical wisdom is very important, and we are really thankful for sharing for you for sharing these insights. I had just a quick question to Dr. Sarkar and Dr. Shumed, because Dr. Shumed also had presented a case where multiple herbs are there. So what is your thought on, in your case, you had not done that qualitative assessment to check that ring, steroid ring, but what is your take if you have HPLC, whether you can go for that to search for some steroid peak, and how you should approach? Dr. Shumed?
Sir, I think based on Saugata
May I
Sarkar
request
sir's
Dr. Silima to please stop that share screen option? Yeah, fine. Thank
Please
you.
stop.
Yes, yes. Thank you.
I think what sir was discussing, Saugata sir, some few qualitative tests like this Lieberman-Bosage test would be quite helpful actually in OPD setting too, actually, if we encounter these herbal medications in daily routine practice or in any tertiary care center. It will be quite helpful actually.
Yeah, that's
to-
but
to the-
what about the HPLC? Any comment from Dr. Sarkar?
We can obviously do, because in our clinical practice area where the more complicated dynamic tests are not available or cannot be performed, even in the Bardhaman, most of the tertiary center it is not performed apart from the medical college, and it is very difficult for the patient to get admitted if it is not truly emergency through the OPD lines. Whatever it is, if we have this simple diagnostic test that we can detect the patient actually has steroid, it obviously would be helpful to early diagnose and start the treatment when we actually suspect this patient is suffering from adrenal insufficiency. And after this presentation and with a communication with Dr. Tripathi sir, I already ordered this all chloroform and this sulfuric acid to the lab that is nearby our clinic, and that if patient present with such type of medication, we can perform this test within 10 minutes and have an idea if this patient actually on the steroid or not.
Right, right. So I think history taking, then some lab report, along with if we can incorporate this, and not analytical, we can say it is a qualitative assessment. So we can actually have some convergent view to the suspected drug. Yes, sir, Professor Tripathi, sir. You have to unmute, sir.
I was just going to mention about you are asking for about HPLC. In HPLC, there are two ways you can look at it. Basically, for quantification. But for quantification, you have to standardize that procedure. For that, you need to know what is the steroid you are talking about. If it is you are looking for prednisolone or dexamethasone, you have to standardize that for that molecule. But you are not very sure when you are talking of herbals. So there could be possibility of different kinds of phytosteroids, okay, in the herbal products. What I mentioned earlier, that it is more likely that there is contamination with synthetic steroids in the so-called herbal products, because truly speaking, as compared to modern medicine products, okay, the herbal products are not that stringently regulated in the country, okay. So they don't really require, okay, the generation of evidence and based on which they are marketed, okay, after the licensing. So marketing of herbal products in our country follows a different route as compared to the modern medicine molecules, okay, or products. So in herbal products, what you need to see that whether like, although we are mentioning, but then if you look at the label of the herbal products, you will find, and this has also been mentioned by in the second this thing Dr. Shumed presentation. So where you will find that we just name scientific name of the plant, and then you say 100 milligram per ml or something, 90 milligram per ml, like that. But which part of the plant, it has not been mentioned. Whether it is an alcoholic extract or aqueous extract, it has not been mentioned. And then again, it is a crude extract, which people might have referred to. Okay, but then there is hardly much of standardization. And again, we all know, this is a common knowledge, that depending on the geographic area from where these particular herbal materials have been collected, how they have been processed, whether they have been sun dried or they have been otherwise dried in some artificial situation. So all these will matter about the content. Finally, until and unless you uh, analyze the active ingredient, active synthetic ingredient, chemical substance into that, it's very difficult to say, and it is very difficult to say how much of that phytosteroid and specific phytosteroid structure elucidation has also to be made. Then only you can say. For the time being, for all practical purposes, you would say that whether a particular product for how long consumption for what duration of time, okay, it is causing these kind of symptoms, and it is perfectly all right when you are advising it is better to withdraw or better to stop those medications, because and you do not know how much they are taking, and if there is even there could be even batch to batch variation to a great extent. Okay, in one batch they are getting certain concentration, in the next batch they are getting different concentration of the phytosteroids also. So thereby the bottom line is there is no need to go for quantitative assessment of the steroid molecule, phytosteroid molecule. The structure has not been elucidated yet, neither in the literature, in the product monologue you will not find them. So we'll take this that they use of these products carries some risk, and we will try to avoid that. And you are very right when you have said there are certain kinds of products, certain kind of materials like ashwagandha as I have mentioned. This carries a greater risk as it comes from the literature. It is better to avoid for long-term use of ashwagandha products, which has the potential to cause HPA suppression. Okay, but otherwise it was very nicely presented, Dr. Sumen, and all the three presentations, four presentations rather, it was wonderful, and it was a great learning experience. Thank you very much.
Thank you very much.
Thank you, sir.
So the bottom line, as sir mentioned, the qualitative assessment we can do, but the clinical suspicion is most important, as we learned from first from Dr. Lakhani, then learned from Dr. Shaugato Sarkar, Dr. Shumed, and Dr. Silima Tarenia. If already we know about some, it could be some complementary or alternative medicine that contains some steroid. Now, the question is what dose we should start with. So again, this is something, because as we know, only we know about the qualitative presence of steroid in that molecule. So may start with Dr. Shenoy, and we'll take the opinion from Dr. Lakhani also here at how you approach in this case and what dose you actually select. So I think this will be the last panel discussion question, because we are approaching to 11.
Yeah. So acetate separation test can be performed determining its cause is central or peripheral. So usually secondary adrenal insufficiency will have hypoglycemia, but not dehydration, hyperkalemia, or same pigmentation. And as you know, the chronic primary adrenal insufficiency signs are anemia, hyponatremia, and hyperkalemia. So when you choose the steroid which you are going to replace, we should know what is the time duration, as sir has mentioned, how much time. So usually we take hydrocortisone is the most physiological among the state. So usual typically is 15 to 20 milligram orally in 2 to 3 divided doses. So largest dose is taken in the morning, typically 10 milligram upon awakening, then 5 milligram at the early afternoon, and 2.5 milligram late afternoon. That is what you usually are taught. And prednisolone can help in some cases where you have already established that hydrocortisone is slowly in the place. But usually monitoring is required, and we also check the values correctly. And if required, morning plasma ACTH is required. And some cases of chronic like additions like picture which we have, then you may have to go for fludrocortisone also, because BP is one thing which hypotension can also be there. Dexamethasone lacks that mineralocorticoid effect, so that is why you will require a additional fludrocortisone when you are giving. So usually don't prefer dexamethasone, but in some cases we really want to do. So you should remember equivalent dose of all these that we all should. And remember that salt intake is very important. So whenever you are doing this, check the potassium, check the salt intake, and whenever possible BP, pulse, edema, serum, and plasma renin activity. So this is what we do. And last is the education of the patient. So whatever you do to the patient, you should give a steroid bracelet, steroid card. So those things never change. So you should tell the patient warning, any surgery is going to happen, any fever or any illness is there, double the dose. So all those things are very, very simple education, but we should not forget it. I usually give a written prescription with my hospital seal. Whenever the patient is going somewhere, I tell them to carry. If they forget it, I tell them to carry in the email. So that is very easy to do. But some cases we really want to do vigilance. Thank you.
Thank you. Thank you. Any last comment from Dr. Lakhani?
No, I agree with Dr. Mohan, and oral hydrocortisone or prednisolone we use as a replacement dose, and like we discussed in the presentation as well. So if you have primary, you also add glucocorticoid because patient will have glucocorticoid deficiency as well, and again you monitor the electrolytes. I think that's something very useful. Some patients, the currently available oral hydrocortisone, some patients kind of do not have a lot of edema also with oral hydrocortisone. So some patients, we consider just giving prednisolone as well, and generally we give either 2.5 or 5 milligram, the lowest possible dose which the patient is comfortable with, and then then you're tapering it off, then we switch again to hydrocortisone. So that is how we generally do it in our practice. Something we again, this is something day in day out. This is our day-to-day kind of work. These kind of patients we see every day. So, and I'll just, add one thing we discussed about cancer patients. Abiraterone, very, very important. I think that something is missed out. What happens, is that there's always this lack of chain of communication. So when the patient gets sick, and this is what Dr. Mohan also said, the problem is the patient might be on the follow-up of the endocrinologist or, some other, physician initially, and the patient would be at glucocorticoid and would be on a track, and suddenly the patient develops some sort of an infection or some sort of disease and goes to a critical care, and then that history is not carried forward. The critical care doctors are not aware that the patient was on abiraterone, patient was on immunotherapy and so on, and then that point of time, it falls between the cracks and the patient does not get glucocorticoids and the patient ends up in crisis. So I think these are often issues. We don't have digital records in India, so there's no it's just you have to rely on the history. So these are often challenges. So I think a lot of the times, that crisis is a problem. Patients developing adrenergy crisis, then things get missed out. So that's a big issue in our country.
Thank you, Dr. Lakhani. And I think we have to conclude now. We are already approaching 11. So as finally, Dr. Shinoy and Dr. Lakhani also had emphasized on education, I just want to say a couple of things regarding this ease. Because when we are talking about ease, this is a program done under the aegis of Clinical Pharmacology Subcommittee of APICON 2025. And this year, the APICON's theme is 3 E's: education, empathy, and ethics. So when we talk about 3E key take-home message from these panel discussions with esteemed panelists and our speaker, Dr. Lakhani, and our case presenters, esteemed case presenters, faculties. So education, we need to educate both healthcare providers and patients about the risk, symptoms, and management of glucocorticoid-induced adrenal insufficiency. We need to provide some clear guidance on recognizing early signs of adrenal insufficiency and the importance of adhering to treatment and tapering protocols to prevent adrenal crisis. Secondly, the empathy. Even if we know the patient is taking some alternative medicine and these or that, not having some proper follow-up, we need to engage with patients by understanding the impact of adrenal insufficiency symptoms on their quality of lives. We need to use this empathy to guide patient-centric decisions, addressing their concerns about glucocorticoid therapy or those alternative medicine therapy and their withdrawal, and reassuring them through some compassionate approach. Finally, the third E, ensure ethical prescribing practices by using glucocorticoids only when necessary and at the lowest effective dose. Promote ethical decision making that includes regular assessment of adrenal function, careful management of glucocorticoid withdrawal to protect patient health and well-being, And as Dr. Lakhani has mentioned about that steroids are candles, it can lighten up, it can omit the जो हम लोग अंधकार बोलता है, ये अंधकार को दूर भी कर सकता है और लेकिन इस आग भी लगा सकता है. So we need to remember this beautiful mantra given by Dr. Lakhani. And at the end, I want to thank Association of Clinical Pharmacologists who were there with us to conduct this CME along with Inovocare E-Academy. And may I request Clarnet because there are, due to some technical difficulties, our Secretary of Association of Clinical Pharmacologists, Dr. Melvin George from SRM Institute, Chennai, not able to present physically in this webinar. May I request Dr. Ritu to please share that video message provided by our secretary, Dr. Melvin George. Please.
Sure, sir. I would just like to have 1 minute, please.
Yeah.
Good evening, everyone. On behalf of the Association of Clinical Pharmacology, I wish to congratulate all.
Sir, is my screen visible?
Yeah, it is. Yes.
Yeah. Okay, sure, sir.
Good evening, everyone. On behalf of the Association of Clinical Pharmacology, I wish to congratulate all the speakers of today's webinar, Dr. Saugata Sarkar, Dr. Sumalya Sen, Dr. Katadi Sumedh, Dr. Selimia Tarinia, for sharing your valuable knowledge on this very important topic of drug-induced adrenal insufficiency. I also thank all the panelists of today's webinar, led by Dr. Mohan Shenoy, Dr. Shantanu Tripathi, Dr. Nandini Chatterjee, Dr. Kaushik Biswas, and the ever-dynamic Dr. Shambho Samajdar, for organizing this event and ensuring that all the delegates of this webinar have a very good time of learning. Wish you all the best, delegates. We hope to meet you all in some other webinars in the days ahead through ACP and Inovocare. Thank you.
Thank you. So I think there was a correction. The candid analogy was given by Dr. Shogoto Sarkar actually. So thank you, Shogoto da, for actually giving that beautiful analogy. And I am again thankful to all the panelists, Professor Shantanu Tripathi, Dr. Mohan Shenoy, and Dr. Kaushik Biswas. And we are really thrilled to have that presentation from Dr. Om Lakhani, the beautiful opening, we can say, opening batting by Dr. Lakhani, just like Sachin Tendulkar. So thank you, Dr. Lakhani. And none other than we have a very good middle order also with Dravid, Ganguly, and VVS Laxman, like innings like Dr. Shogoto Sarkar, like Dr. Sumedh, and Dr. Silima. So that was a fantastic score, I think, for all of us, all of the physicians, all of the clinical pharmacologists who were there with us for almost 2.5 hours. So I think this will be stored with all your permission, and it will be for future references. And thank you once again for this beautiful webinar.
Thank you so much, Dr. Shah.
Thank you so much. Nice.
Thank you, sir. Thank you.
Good night.
Good night.
Good night.